Good afternoon and welcome to today's clinical webinar on ADHD. My name is Dr. Ed Gaynor and I'm a paediatrician by background, and I've been asked to share with you today a practical guide to ADHD. As many of you will know, there are many challenges and misconceptions around this condition, and I hope I will be able to provide you some clarity by the end of today's presentation. I intend to cover the definition of ADHD, how it presents in both children and in adulthood, and how professionals diagnose and manage it. Today's talk will not specifically address our insurance policies, but I'm happy to chat later about this if it's helpful. So I wanted to start with a bit of interaction from the group, particularly looking at what symptoms people feel a child or an adult with ADHD might demonstrate. Okay, so we've got impulsivity and hyperactivity. Any other points or comments?
Anxiety?
Yeah, fabulous.
What about tics, Ed?
Yeah, they do get tics as well.
Hyperactivity?
Yep. So exactly. So there are many presentations, as you can see on this slide, with how both adults and children present with ADHD. But actually, beyond the diagnostics, it's really important to think how these symptoms impact both an individual and their family. So this brings me on to one of my colleagues, Bernice, who is kindly going to speak to us today about her experience of children and families with ADHD. I'd like to welcome Bernice Knight, a higher trainee in mental health in young adults and those with learning disabilities. To start, Bernice, I understand you wanted to share a story of a young adult diagnosed with ADHD.
Yes, very recently I received some good news about a patient who has responded very well to treatment for ADHD, having gotten to the age of 18 without anyone having questioned it before. The young adult had a diagnosis of autism and also of a severe learning disability, so her language was very limited. And I think that overshadowed the fact that she actually had quite a considerable ADHD component as well. And because of her other diagnoses, no one had ever questioned it, or certainly hadn't gone to professionals questioning it. And this has had a profoundly negative effect on her life. Having seen the difference with treatment, it's now possible for her to sit still for up to 15 minutes. What that has meant is that educationally, she's starting to achieve more. Prior to treatment, she had not really been able to sit still in a seat for more than a couple of seconds. The first time I met her, she was intensely agitated. She always seemed quite happy with it, but intensely agitated, unable to sit still. Even when she was eating her dinner, she would sit up, she would stand up and sit down and stand up and sit down, and had to be sort of almost followed around by family members to make sure that she didn't accidentally hurt herself. What that meant is that it was difficult for her to build relationships. It was difficult for anyone to engage in learning how they might communicate with her better. And also because of the untreated ADHD, she had terrible sleeping patterns. So as I began the story, it was great news to hear what a fantastic response she'd had to treatment. And I think that had made quite a profound effect on her life and her family's.
So, as many of you know, ADHD stands for Attention Deficit and Hyperactivity Disorder. And although we'll go into more detail in the coming slides, the important features to note that ADHD is a developmental disorder, that it is characterised by hyperactivity, impulsivity and inattention. And although these presentations can be highly variable between individuals, these symptoms do need to be severe and present in more than one setting. So, for example, not just at home, but at school or in another context. And it needs to be severe enough to affect normal living, such as study or interpersonal relationships. It is also important for from a clinical point of view to exclude other conditions that might be a main cause of these symptoms. So Bernice mentioned about a child with autistic spectrum disorder. There are other disorders that can present in very similar fashion, such as anxiety disorders, mood affective disorders, other disorders like schizophrenia. So as part of the workup is looking at both the presentation but other comorbid presentations that can coexist. So as mentioned on the previous slide, ADHD is characterised by extreme problems in concentration, out of proportion to a child or young person's age and development. The second feature seen is hyperactivity or excessive motor activity. Older age children and adults are often present with restlessness. And the third feature is impulsiveness, doing or saying things without thinking. And although there are various subtypes, one of particular note is attention deficit disorder. These children or young adults are predominantly affected by inattentiveness, and it is much more common in girls than boys, and they can have an element of impulsivity. So in your practice, children who have and adults who have some of these features may fit one of the subtypes rather than the full attention deficit and hyperactivity disorder. So how common is ADHD in children? ADHD is the most common developmental disorder of childhood. There are various figures both in the UK and internationally, but 2 to 5% of school-aged children are believed to be affected. ADHD is a complex disorder, and by a complex disorder I mean that it's not explained by one gene or one environmental factor. That it applies to many disorders in medicine, be it diabetes or asthma. But it is still very hard to identify what may be causing ADHD. We know there must be an element of environmental factors that are responsible for ADHD. So, for example, prematurity, a low birth weight, maternal smoking or alcohol use has been associated, but equally genetics do play a role. A family history is associated with an increased prevalence of ADHD, and the risk of ADHD in parents or siblings of children with ADHD is increased between 2 to 8 times. It is, however, rare for children to be referred before school, mainly because in toddlers there's a lot of variability in behaviour and development. But at school age, it is much easier to identify behavioural issues or differences in how they play. So, for example, most 2 or 3-year-olds will be able to settle down eventually, but you'll see children with ADHD will often flip from toy to toy or activity and also demonstrate poor concentration. So what about adult ADHD? We used to think that adult ADHD was limited to childhood and they would grow out of it in adulthood. And there are numerous studies that have followed children into teenage years and into adulthood. And these have shown that while some individuals have improvements in regards to their hyperactivity and impulsiveness, the concentration problems tend to remain. Having a good process of managing ADHD, and in particular that transition period between childhood and adulthood, is very important. And therefore, medical, educational and occupational approaches are crucial to minimise its effects in adulthood. So a study looking at what childhood factors might lead to persistence of symptoms in adulthood showed that the severity of ADHD at presentation, comorbid disorders, which I will come back to, or mental health problems in either parents were the most influential factors for continuation of symptoms into adulthood. But how those symptoms actually progress into adulthood is very different to what you see in children. So it can be hard to ascertain the impact of ADHD on adult life. Clearly, there are many other confounders in adulthood. So this graphic summarises the various areas that can be impacted, with inattention often being the strongest component for those who are affected. And this can present in difficulties in remaining focused on a task, especially for long periods, organising activities, prioritising tasks, and following through and completing tasks. But furthermore, there are problems with both forgetfulness and time management. Now, this is not just limited to adults with ADHD, but the impact of those symptoms on daily functioning is where the crucial difference is. but it does make it a great challenge when coming to diagnosing these patients. So I've mentioned comorbid psychiatric disorders before, and indeed I know a few of the policy people on the call today have come to me going, actually, how do we pick these bits apart? So the rate of comorbid psychiatric disorders in adults with ADHD does tend to increase with age, and findings suggest that there is an increased likelihood of anxiety, depression, substance use disorder, and antisocial personality disorder increase with the rate of ADHD, and they often become much more evident with greater age, whilst the underlying ADHD becomes less evident. A sad reflection on, I suppose, our management in the past is that the rate of ADHD in those who are in prisons or in the criminal justice system is much higher than the population mean. And again, this is why it is a disorder that we should take seriously beyond the initial impacts in school. So moving on, so how do professionals evaluating diagnose those affected with ADHD? The diagnosis is clearly challenging, and so again we join Bernice talking about these challenges. Are there any other challenges that you see in your work with diagnosing ADHD in children and young adults?
Yeah, and it certainly can be a challenging diagnosis. So no one should feel that that it's going to be necessarily straightforward, or if it was missed, that was because of someone not doing their job properly. It can be a difficult diagnosis. I'd say the most common reason why it's not diagnosed when it's present is because of comorbidities. And by that, I mean people very often will have autism or an anxiety disorder or obsessive compulsive disorder, and those can overshadow the ADHD. The next barrier is often time. To make a diagnosis of ADHD, it's important to see the child or young person, ideally seeing them yourself in at least 2 different environments. So ideally home, a learning environment. If not seeing himself, at least taking a very detailed history in those environments, as well as, because it's a neurodevelopmental disorder, clear developmental history. So that requires both time and also access to individuals who can give really reliable information.
So as Bernice said, as part of the evaluation in children, we start with a medical, developmental and behavioural evaluation. Prenatal and perinatal history is very important, as is family history or any other medications. And it does get much more tricky when we start performing our developmental and behavioural evaluations. Understanding the impact of symptoms on daily living is crucial, and asking open-ended questions to get a full picture of a child's presentation and using rating scales can be really helpful. Another question I got prior to the presentation was talking about these various rating scales. The use of ADHD-specific rating scales focus directly on the symptoms of ADHD and can be used to establish the presence of core symptoms, but they also give us information about symptoms in multiple settings, for example, school and home, and allow us to characterise severity of the presentation. Additionally, it is useful to see whether any treatment interventions have worked. So on the screen right now is the Conners scale, and as you'll notice, there's a number of sort of questions that come up. The questions you hear are based actually on the American version of the Conners rating scale. So, for example, being sassy to grown-ups is one of their questions. Ours are essentially identical, but with just slightly different terminology being used. Then the role of other investigations can be of help, and in particular for the assessment of other co-existing conditions, such as autism, for example. However, there are some investigations that really are not helpful, and you do see them on occasion. So, for example, psychometric testing or quantitative EEGs. So in practice, what does this mean is that both for children and adults, they should really be seeing teams who are very experienced with ADHD, and that they can assess without the need of non-validated investigations such as these two. So how about the diagnosis in adults? As Bernice outlined earlier, this is really challenging. The presentation of hyperactivity, impulsivity, and inattention can be varied, and the increased prevalence of these comorbid conditions, such as learning difficulties, can cloud the picture. Again, by using specialist teams and rating scales, these can be helpful in your diagnosis of ADHD. I'll just pause for a second for you guys just to read through the various presentations in each of those areas in adulthood. So what next? So I think what I wanted to emphasize in this talk is just actually the impact of ADHD. It clearly affects all ages, but also your progression through life. And so how we approach treatment is crucial to make sure that at each of these age groups, the individual affected gets the most out of them. And for example, the case that Bernice brought up, if they are picked up slightly later than early childhood, is making sure that you impact aggressively at this stage to make sure that they have a normal adult life, in particular related to occupation, relationships, and other comorbid conditions such as substance abuse. So on this slide, I sort of demonstrate the several avenues for treatment. Starting with behavioural treatment for those who are mildly affected, medical treatment for those where it is impacting on daily functioning, though in practice this is often in combination with behavioural management, and then good education for both families and the affected individual, as well as good educational support services. The way that this is enacted is different in different areas and different countries, but they broadly all have these similar pathways in place for children and adults suffering from ADHD. Now, in regards to behavioural treatments, there are various behavioural strategies that are used particularly in children, with the use of CBT, so this is cognitive behavioural therapy, being more commonly used in adolescents and in adults. And again, the support for the family, their partners in adulthood, as well as school or occupational settings is crucial for success, as well as having empathy for the condition and how it affects these individuals. Now, in terms of pharmacological agents, although many children do often escalate into these agents, the importance of behavioural therapy first is outlined in most national and international guidelines. For those who do require escalation, stimulants are our first line, and those on the call will be familiar with the short-acting agent Ritalin. There are, however, various other options, both short and long-acting treatments, as well as more novel therapies. The importance with treatments is also tailoring them to the lifestyle of the child themselves. So, for example, it's not uncommon that children will only take their treatments during the school week, but have breaks at weekends or on school holidays, or alternatively only have them when there are important life events, be it a job interview or an appraisal. There are side effects, however, such as reduced appetite and insomnia, and these can be very debilitating. And therefore, only those who are severely affected, and by that I mean having effects on their daily living, should really be medicated. But for those who do require medication, it is actually often very effective, particularly on symptoms of inattention and concentration. And this clearly can have a wider impact on a child's or adult's life, both academically and occupationally. Now, I was going to pause at this point to sort of get an idea of people's exposure to ADHD and any questions you might have. And then I was going to end on a final note from Bernice, sort of telling me why she's passionate about ADHD and why we should all be making steps to make sure it's diagnosed in childhood and adulthood.
Is now disabled.
So opening up to questions. You can do this either on the chat function or you can do it through your phone, whatever you're happy with.
Hi, Ed, it's Johnson, mental health nurse.
Hello.
UK customer. Hi. One of the things that we struggle with quite a lot here in policy, and I know that you're not talking about policy as such, but when we get a report in asking us to agree an assessment for ADHD, often we struggle with how do we know this is needed when a lot of it comes from the parents and it's all to do with the, to us it may just look like a normal childhood behaviour. So often the parent will go and see the GP and the child never does. And the parent says, oh, they don't do what the sibling does, they don't do these things, which is quite common. But we then struggle then thinking, okay, the child might be, presenting with one symptom of ADHD and none of the others, but the parents are quite sensitive and quite pushy for those assessments all of the time.
Yeah.
Is there any kind of tick list, I guess, that we should be looking out for when we're thinking about whether we should or shouldn't go for an assessment of ADHD?
Yeah, I agree. It's difficult, and as Bernice mentioned, and I will sort of mirror her comments. It's not straightforward, and I think that's probably where it's led to difficulties in terms of both recognition that ADHD is a condition, but also from our side of things of applying policy. I mean, I think what the main question from that is, what do you think is normal child's behaviour? So when I started in paediatrics and in the behavioural side of things, the first bit of advice I had from my bosses was listen to the parents. They are the expert in their child. If they think something is wrong, then actually they are probably right. Now, that does come difficulty with policy, which is why I will touch on it briefly. But getting to that point of diagnosing it, actually the question often comes from the parents or it comes from the teachers. So what could you ask from that is, firstly, why are they concerned, and trying to work out is it parental anxiety. But the second thing is have they noticed it in any other place. So, for example, you'll find most of the time, the teacher has spoken to the parent. The parent has gone, oh, you're right, it's not just my child being sort of a bit outlandish. They will then go to the GP and get the referral. It's not that common. You get it from education in the early school years. So I would ask them why they think it's not normal. Ask them if they've seen it anywhere else, and what do their teachers or schools think. But I think in all reality, it would be very difficult for us to say no from a policy point of view if there's parental concern.
Okay, thank you.
Thank you. You can put yourself back on mute, and then any other questions? Any questions from the room?
What would you advise a parent who suspects their child has ADHD? So should they sort of monitor their behaviours for a while and then go and see their GP, or what would you advise them to do in that situation?
Thank you. Good question. Maybe I shouldn't have opened it up. No. No. So what would I advise a parent? I think, again, same thing as I reiterated previously. Trust your instincts if you think things are not right. But it is speaking to other people. So within your social group, it's speaking to other family members or other people who have children of a similar age to ask if they've noticed any differences. It is definitely speaking to the school or the nursery and going, again, do they notice any changes? I think it is sometimes a bit difficult when you go, is my child badly behaved in all settings? But is to see, and I suppose the next step of what we would do professionally if there was concerns is actually within a clinic room, you're sort of seeing what they're actually doing, and GPs and teachers are completely au fait with what is normal. But then we do often go into the school or into other settings to see what they're actually doing, because some children are just very sort of hyperactive and they love running around and they haven't got it's not actually impacting on their life, they're just full of energy. And I would say that was certainly my childhood. But I like to think I can and have always been able to concentrate. And I think that's the bit, is if your parents are concerned, then they should should ask around, ask their GPs. GPs are sensible. They do. Most of them have been in the business for years. Speak to your health advisor or your school nurse, and then reflect on that. And then if you're worried, ask for help. This is what us paediatricians and psychiatrists are around for.
Thank you.
I've got from Emma Roberts asking what hormone changes do you have in the condition? I'll be honest with you, Emma, not a clue. So what you do often actually find with these children is that they do exhibit higher levels of anxiety and stress. So there are studies showing that there are higher levels of cortisol hormones, but actually whether that is a cause or an effect, I think is probably quite hard to show. One of the things that is probably important is when we talk about medications, is a lot of them do affect your blood pressure, and it does that through hormonal mechanisms as a side effect. And so one of the things that we would do is monitor blood pressure, and it is often a concern that parents will have before they start medications, because it's generally in bold in any of the information leaflets. Are there any other questions anyone wants to ask before I move on to Bernice?
Hi, it's Pam Garrison.
Hey, Pam.
Ed. I think there are other healthcare professionals that are involved in the diagnosis or can be involved in the diagnosis, aren't there?
Yeah. So if the question is what other professionals, I'll go through that. So in childhood, your main professionals will be your actually, I'm going to put the parent and the child first, because actually I think they're probably the biggest professional in this. It is your GP, often in terms of coordination. The initial structure within medicine will either be referral to a psychiatric based unit or mental health based unit, and that's often through psychologists based in the community, or it will be down a community paediatric route and that's often if there's concerns about overlapping developmental disorders. And then the most important bit actually is probably the school, and actually the doctor is probably the least important in all of this. And the school, there are the teachers, but the educational psychologists. Unfortunately, the educational psychologists are few and far between, but a lot of their role is actually trying to correlate the child's developmental level with their educational level. So the thing that you often find, actually, or not often find, but you find as a confounder is you have children who are actually developmentally very advanced and actually very intelligent, and the reason why they're acting out and they're hyperactive is they're just not being challenged. And in all fairness, as a clinician, you just cannot pick that up in a clinic room or on a half-day observation in school, whereas the educational psychologist can do. Does that answer your question?
Yes, thanks. I did. Captain Johnson, I just have one final question. When I know you said earlier on about policy, etc. Do you have any time following this call to have a chat with you and the other nurses and perhaps about how this fits in with policy decisions?
Yeah, no, I'd absolutely love to, and I think with these ones in particular, which is sort of why I was quite interested about people's experiences of people with ADHD, is that it's understanding the impact and how that makes you feel actually, and trying to navigate that system. Because I think our role is often signposting these parents or these adults about how to get help is really helpful, because there's nuance clearly in all policy. So yes, totally. Send me an email afterwards and we'll set up a meeting. That'd be lovely. I've got another meeting another question from one of our colleagues who's been asking about some adults with ADHD and their comorbid conditions such as anxiety can have frequent relapses. So what should we really be doing to try to help them? So I think there's not necessarily a straightforward answer to that. I think the first bit is probably recognising that they are connected, but they're not part and parcel. So we know that people with ADHD do have higher rates of anxiety disorders, and they often have poorer coping strategies, mainly because of their impulsivity. But the anxiety is both a separate and leads on to their problems with their ADHD. So the main bit would be focusing actually probably firstly, is their ADHD being managed? Have they had it assessed? are they under any professionals? Now, I know we don't fund treatment, but that doesn't mean we can't make sure that the GP's involved and that someone's thought about it. And that comes back to a lot of misconceptions that adult ADHD doesn't exist. It does. The second bit is the anxiety bit, and this is where things like CBT are great. And it does help with anxiety, it does help with ADHD, and there are certain medications that certainly also help with both of these conditions. So, for example, some of the serotonin reuptake inhibitors. So these are the antidepressants can manage both of those conditions. It is complex, and so I think from our role within Bupa, especially on the mental health lines, is actually making sure they're being signposted to the right people, rather than necessarily trying to do all of it through our crisis teams or our EAP teams. Are there any other questions?
I just have one, if that's okay.
Yeah.
It's a fascinating WebEx. Thank you, Ed. Really have enjoyed it. It'd be really useful if you have any further reading you can share with us all, just so if we're really interested in the topic, we can read up in our own time.
Yeah,
a bit of extra CPD as well.
I would love to. So I think in terms of immediate things to look at, NHS Choices actually has an amazing website talking about ADHD. Again, talking about things like diet, talking about various treatment options and risk factors, because I think the risk factors is what probably a lot of new parents worry about in terms of behavioural disorders. The second bit is there's a professional grouping for ADHD in terms of both support function, so for those people affected, but also for clinicians involved. And what I'll do at after this is when we send out our sort of feedback forms and comments, we'll attach those details to that. But I'm more than happy to answer any questions, and we can go from there. And then the final bit actually related to resources is we now have access for the BMJ, which has an amazing sort of grouping of all medical, psychiatric, developmental sort of disorders, and has a built-in CPD function. So if you've got any questions, please speak to Joe or Sophie about that. Okay, so I'm going to end on...
Presentation mode is now enabled.
Hey guys, I'm going to end on Bernice talking about why it's important to diagnose ADHD, and then if there are any questions or comments afterwards, please do just bung us an email. So finally, Bernice, what do you see as the benefit of diagnosing children or young adults with ADHD?
Well, the first thing I'd like to say is that ADHD is a really treatable condition. And by that, I mean the multiple different ways that you would try and improve a person's life with this diagnosis. So that includes educational adaptation, home environment changes, and also for some people, medication. And because it's so treatable, and also because it can make such a profound improvement for people's lives, I find it a really satisfying condition to be able to diagnose and to treat, because it is a condition when it's present can create profound disability. Not the physical sense, but in the psychological and social sense. It can create such disability where individuals and their families can't leave their home, can't go to birthday parties, are fearful of going to school. That when you make improvements and when you make a change in that for the individual and their family, it really can be life-changing. So although it's complex and it can be a tricky thing to diagnose, when it's done right and it's done well, it is really satisfying that, as I said, has life-changing effects for young people and their families.
Well, thank you very much, Bernice, for joining us today.
My pleasure. Thank you.
Fab. So I'm going to leave on the final bit is our email address for comments and my email address. Should you have any further questions, the plan will be to share this. And I'm going to end up with Joe finishing.
Thank you, Ed. That was a great presentation. Thank you for joining us, everybody. Enjoy the rest of your day, and goodbye.